Okay, historically, until maybe 5 years ago, the only therapy we had for HCV was interferon ribavirin combination, both, not monotherapy with either one, but combination. The problem is that we had unpredictable response to the combination, and in particular, genotype 1 had a low level of response. And when we looked at the resistance to, or what caused the response, it wasn't associated with viral mutations. It was actually from host factors that have polymorphisms that seem to be associated with it. And you may hear reference to IL-28B. So we had these two drugs. We actually were sequencing this gene to look for, or at least predict, whether we would get a response to interferon ribavirin. So we already discussed interferon. It's the exact same interferon, pegylated interferon that we use for HBV. Ribavirin, the mechanism of action is it's a synthetic purine nucleoside analog, but we don't really, it's been around a long time and we really don't know exactly how it works. It seems to deplete the intracellular purine concentrations, such as GTP, and there looks to be some inhibition of protein synthesis and inhibition of the RNA polymerase, which you might predict because it is a purine nucleoside. However, now that we have what we call direct-acting antiviral agents, or DAAs, there are some protocols which still will throw in ribavirin. We'll see as we go through those. Not interferon. So you're not going to hear me say interferon when we start talking about the rest of these agents. So the activity of ribavirin is against all genotypes, so that's pan-genotypic. Where we actually most often heard about ribavirin is in treatment of respiratory syncytial virus with kids. And also it sort of is the jack of all trades for RNA viruses. Whenever the people think they need an antiviral agent for an RNA virus, they just test ribavirin. But we don't really have good data or studies that have proven that that's efficacious for other viruses. And examples are Lassa fever virus and hantavirus, which are very serious RNA viruses, and so you really would like an antiviral agent. But so far, it hasn't been proven totally efficacious. It's given orally in 2 doses, and you'll hear reference to weight-based ribavirin. So what they've done is they've taken a cutoff of 75 kilograms, and those that weigh less get 1 dose, those that weigh more get more. And this will be, as we'll see, in protocols that use the DAAs. It also can be given by aerosol for kids for RSV treatment. As far as interactions go, it will interact with some HIV nucleoside analogs, and that is not that it has antiviral activity against HIV, but it causes changes in concentration of some of these nucleoside analogs. You'll come across these in the 3rd installment of antivirals in the last block when we go through HIV antivirals. It does produce pancytopenia if it's co-administered with azathioprine. One of the major complications is hemolytic anemia, and this can lead to a worse condition in patients that have cardiovascular disease that is actually secondary to severe anemia. There are some relatively benign other complications, but one thing also to remember, it's a significant teratogen, so that it's considered pregnancy category X. So it should not ever be given to a pregnant woman or her male partner because it's also been found in semen. And it should not be given to patients who have significant cardiac disease. So let's go into the direct-acting antiviral agents, which essentially have exploded in the last few years. And so I apologize for the density. Our long-term goals have been for HCV therapy, first of all, to have an interferon-free regimen. And you'll notice as I go through the DAAs, I'm not going to mention interferon again. A combination of drugs that target different viral functions. And this allows you to avoid resistance. A single oral dose of the combination. Drugs that are pan-genotypic, that means they will they're effective against all 6 genotypes of HCV. Remember, there are 6 genotypes. And that we get a sustained virological response, which is usually defined as treatment for 12 to 24 weeks, stop treatment, wait 12 weeks, and look to see if the patient is still aviremic. And if the patient is, we consider that a sustained virologic response. With interferon ribavirin, here I'm saying interferon again, interferon ribavirin, we didn't often get a sustained virologic response with therapy. And I'm giving you here the link to the guidelines for HCV, which, similar to those for HBV, is updated periodically and is a good source of information for therapy. Now, I think you saw a similar picture with Dr. Wong. I'm just bringing this up because we have 3 drug targets for HCV: the protease, NS5A, which we really don't know exactly what it does, and NS5B, which is the polymerase. Now, they have a nice trick, which fortunately it has held up with nomenclature for HCV genes, drugs. So if it ends in Previr, such as Semeprevir, it's a protease inhibitor. If it ends in Asvir, such as Ladipasvir, it's an NS5A inhibitor. If it ends in Buvir, such as Sofosbuvir, it's an NS5B inhibitor, which is also a polymerase inhibitor. So you don't have to exactly memorize the names. If you can just recognize that the drug is against HCV, you can predict what the target is, which is nice. Unfortunately, with HIV drugs, it's not that neat. And I also wanted to bring up the Child-Turcotte-Pugh score, or sometimes it's just the Child-Pugh score, which is a way to assess chronic liver disease. So the measures are bilirubin, albumin, prothrombin time, or the INR, ascites, and hepatic encephalopathy. So these are assessed, given point values, and then depending on what the total point is, you get a grade for the score. So grade A, which is the lowest, it's mild disease, well compensated. Grade B is moderate, significant functional compromise. And then C is severe decompensated disease. And you'll see as we go through the drugs that this plays a role as to whether you can use the drug concentration in our combination for a patient with information. So let's start with Sofosbuvir. This was one of the first drugs that was approved as a directly acting agent. It's a nucleotide analog, so it's going to target the RNA polymerase. It's also a prodrug, which has to be converted to the active form. The good thing about it is it's pan-genotypic, so it's effective against genotypes 1 through 6. It's given once a day. As far as interactions go, it's a substrate for P-glycoprotein, which is a drug efflux pump. So you don't want to give it with inducers of P-glycoprotein because this may lead to a lowering of the concentration of Sofosbuvir. So you're going to see when we talk about a lot of these drugs that we have to worry about the effect with co-administered drugs, but not exactly the activity, the antiviral activity. So it's generally well tolerated, and it has a high genetic barrier to resistance. Semeprevir, so if you look at it, it's Previr, so that's a protease inhibitor. It's recommended for treatment of genotype 1 when it's administered with Sofosbuvir. So these are individual drugs. As you'll see, we're going to get to combination drugs in a little bit. So Sofosbuvir can be given by itself, Semeprevir can be given by itself, but usually they administer them together. It's metabolized by the CYP3A enzymes, once daily dosing. So here's where the Child-Pugh score comes in. It's not recommended if there's moderate to severe liver impairment. So that's grades B or C. It interacts with moderate to strong inducers or inhibitors of CYP3A. And this is just a very short list. I'll give you something in the end that sort of gives you a hint of how many drug interactions you can have with these particular antivirals. I'm not sure how people take drugs, period, after that. There are many antiretroviral medications also that are involved. Protease inhibitors, which makes sense because Semeprevir is a protease inhibitor, and non-nucleoside reverse transcriptase inhibitors. You'll hear about these in the next block. But in this case, we're not treating HIV, we're just interfering with drugs that are used to treat it. So it's a different scenario. some relatively mild complications. One of the major problems is there's a baseline polymorphism in genotype 1A that is Q80, it's glutamine 80 to lysine. And it's a naturally occurring polymorphism, so it can produce resistance. So it's advised that you screen for this mutation before you initiate therapy with cimeprevir. The cladosphere is an NS5A inhibitor. It's also for use with sofosbuvir for genotypes 1, 2, and 3. And you can throw a little ribavirin in if you have genotype 1. Once daily dosing, but in this case, you're getting 2 tablets because you have one for sofosbuvir and one for declatosphere. And then if you have ribavirin, you got another couple of pills. It's an inhibitor of P-glycoprotein, so it will increase levels of drugs that are substrates for P-glycoprotein. It's also a substrate for CYP3A, so there may be dose adjustments required for strong inhibitors of, or moderate inducers of CYP3A. And here are a couple of examples, but believe me, there are many more. I'm just trying to get you a feel of what some of the drugs might be. There are some complications that are relatively benign, but you can have bradycardia if you co-administer it with sofosbuvir and amiodarone, which is an antiarrhythmic. Resistance mutations depend on the genotype, but we can get cross-resistance to other NS5A inhibitors. The resistance story for HCV is not as defined as it is for HBV. We're just beginning to understand there's so many modifications that can be made because of the error-prone nature of an RNA polymerase that it's going to take a while before we know all of the resistance mutations that might cause a problem. So now, those 3 drugs that I just told you are available as single pills. What's happened with the companies, as you'll see, is they make combination drugs, which means that it's fixed combination, you can't alter the dose. And it's also a problem because you can't mix and match drugs from different companies. So you're pretty much stuck with the fixed dose combination. So ledipasvir, that's an NS5A inhibitor, with sofosbuvir, which is our polymerase inhibitor, it's used for HCV genotypes 1, 4, 5, and 6 when it's administered with sofosbuvir. So actually, this is a fixed dose combination. Given once a day, substrate of P-glycoprotein, it interacts with inducers of P-glycoprotein, those listed. Some relatively small complications and a high genetic barrier to resistance. So it's a good combination. But as you can see, genotypes 2 and 3 are not recommended. Now, this combination is driving me crazy. Abitavir, paritaprevir, and ritonavir. There's an NS5A inhibitor. There's an NS3 or protease inhibitor. Ritonavir has no antiviral activity against HCV. It's actually a protease inhibitor that was developed for HIV. And in both cases now, it's not used as an antiviral agent. It's used because it's a strong inhibitor of CYP3A, which means it raises the plasma concentration of drugs that are co-administered. So in HIV, we refer to boosted regimens, which contain ritonavir. And the idea is that it boosts the concentration of other proteases that are given with it. Here, it boosts the concentration of paritaprevir, which is a protease inhibitor. So remember, ritonavir is a boosting agent, not really an antiviral agent. And certainly with HCV, there's no activity. This combination then can also be given with ribavirin for treatment of genotype 4. But again, you can't use it except if there's mild cirrhosis, which is class A, child Turcotte-Pugh. And it's given once a day. Okay. So it interacts and it's contraindicated for drugs that are highly dependent on the CYP3A clearance pathway and for strong inducers of CYP3A and P-glycoprotein. Notice there are quite a lot of drugs here, and again, this is not an exhaustive list of drugs that interact with it. And of course, if you add ribavirin, you're going to add some more complications and interactions. Relatively mild complications, though, just for the combined therapy, but you can have serious liver injury in patients that have underlying liver disease, which is why we can't use grades B and C, use it for grades B and C liver pathology. And we do have resistance mutations that have identified. We would expect that there will be cross-resistance with other drugs in the classes that are represented, which is NS5A and a protease. And actually, because you have a protease inhibitor here, that increases the possibility of resistance mutations. Now, we just told you about this combination. We said we could throw in ribavirin, but they also have another combination. It's the same combination pill, but they co-package it with dasabuvir. And that tells you with buvir that it's going to be targeting the RNA polymerase. So we have umbidasvir that we just had, NS5A. We have paritaprevir, which is a protease inhibitor. We still have ritonavir there to boost the concentration of all of those. And remember, it doesn't have any HCV antiviral activity. And then dasabuvir is going to target the polymerase. So we're essentially covering all the targets with this combination. And it's used for treatment of genotype 1A if you add ribavirin, and 1B if you leave out the ribavirin. And in each case, it only works if the patient has mild cirrhosis. It's given once a day for the combination, but dasabuvir requires twice daily dosing. So now you're adding 2 more pills. And of course, if you have ribavirin in there, you got additional pills. It's not recommended, or it's contraindicated if there's moderate or severe hepatic impairment, which we talked about with the CTP class B or C. And it will interact with all the drugs that are metabolized by the CYP3A pathway. Essentially, it's going to have the same complications we had without dasabuvir. We have relatively mild complication or toxicity, but we can have serious liver injury with patients that have underlying liver disease. It can be administered with ribavirin, as we talked about, and we do have resistance mutations which have been identified. And again, we're going to expect that there will be co-resistance or cross-resistance with NS5A and NS3 protease inhibitors. Now, what I want to say about this, I'm not sure why this preparation is approved and used. It is, in the guidelines, it's listed as an alternative protocol, but it's acceptable and it's approved. But it's got a huge pill burden, lots of complications. I'm not sure why. It is used for genotypes 1A, 1B, and 4. So it may be that there's been more difficulty in treating those particular genotypes. But as I said, it's not a preferred regimen. It's just they keep adding more and more drugs to it. Okay, so another combination, velpatasvir, it was only approved, I would say, in the last year, and is approved in combination with sofosbuvir. So we've got an NS5A inhibitor and a polymerase inhibitor, and it has pan-genotypic activity, which is great. Single dose. Both of the drugs are substrates for P-glycoprotein, and it turns out velpatasvir is also an inhibitor of P-glycoprotein. So you don't want to give it with drugs that either induce P-glycoprotein or inhibit it, and we can end up with lower sofosbuvir levels with the interaction. And co-administration with amiodarone can produce bradycardia. Excuse me. So mild general complications. There has been resistance detected in cell culture, but we haven't determined if there's cross-resistance to other NS5A drugs. Now, voxilaprevir was just approved, I would say, in the past 3 months. So we're adding now a protease inhibitor to a combination that had NS5A inhibitor and a polymerase inhibitor. So we're covering all of the targets. And as might be expected, it has pan-genotypic activity. Single dose with all 3 drugs, but essentially that means 3 tablets taken once a day. It's not recommended for higher levels of liver damage. All the drugs are substrates for P-glycoprotein, and velpatasvir is an inhibitor. And it has the same cautions to not be given with inducers of P-glycoprotein or inducers of the CYP enzymes. One thing, whenever you see CYP, start thinking, as I said, drug-drug interaction, because it's likely it's going to have one. Co-administration with amiodarone can also produce bradycardia, and it can interact with a number of HIV antiretrovirals. These three are protease inhibitors, well, that includes ritonavir, and then, as you remember, tenofovir is a nucleotide analog. We have relatively low level of complications, and there has been some resistance detected in cell culture. Elbasvir and grazoprevir are an NS5A inhibitor and a protease inhibitor. They were just approved this past year. It's recommended for genotypes 1 and 4, so they're not pan-genotypic. Once daily dosing, not recommended if you have child Turcotte-Pugh class B or C liver damage. Both the drugs are substrates for CYP3A, so you can tell that there are going to be a lot of drug-drug interactions, either with inducers or inhibitors. Few complications. It's thought that you should test for NS5A resistance mutation before starting therapy. And then the last combination is glecaprevir, preventosvir, which was actually just approved in the last 2 to 3 months also. We have a protease inhibitor and an NS5A inhibitor. It's pan-genotypic, which is definitely desirable. There are 3 tablets that are given once a day, and 3 tablets are the same concentrations of the 2 drugs. So you're actually taking 3 pills, but they're all the same, and taking it only once. It's not recommended for class B or C, child Turcotte-Pugh. Both drugs are inhibitors of P-glycoprotein and substrates of CYP3A enzymes, so you're going to have drug-drug interactions, obviously, with inducers or inhibitors of CYP3A. And the complications are relatively benign. So to summarize for HCV, the original therapy was interferon ribavirin, but only about 50% of the patients that had genotype 1 actually achieved any kind of response. And genotype 1 happens to be the most common genotype in the US. So obviously there was a strong motivation to try to increase the antivirals that were available for that genotype. We now have interferon-free regimens, which are the directly acting antiviral drugs, or you'll hear DAA. So you can see I haven't mentioned interferon in reference to any of the combinations. There are 3 viral targets: the protease, the NS5A protein, which we don't know what it does, and the polymerase. We still, at this stage, have to consider the genotype and the level of fibrosis or cirrhosis for determining what would be the recommended regimen for a particular patient. Combinations of sofosbuvir with either ledipasvir or velpatasvir plus voxilavir have been very successful regimens, and these may eventually take over as the most widely used or recommended regimens. They've been successful in getting a sustained virologic response in multiple or all genotypes. And NS5B is the replicative enzyme. We don't have, what you'll note is it's an RNA-dependent RNA polymerase, so we don't have any DNA stage in the replication cycle of HCV the way we do with HBV and HIV. So keep that in mind. The protease activity is similar to that of HIV drugs, but there's no cross-reactivity. So if you're treating HCV with a protease inhibitor, it's not going to have any effect on replication of HIV. Unlike what we saw with the hepatitis B viruses, where one nucleoside analog was actually had activity against both HIV and HBV. NS5A is a new target of the approved drugs. We don't understand the activity well, but note there's no homologous activity in either HIV or HCV. So in co-infection, again, if you're treating with an NS5A inhibitor, you don't have antiviral activity against HIV or HBV. We have drugs with different targets that we can use in combination regimens. And this, because it's an RNA virus without any DNA provirus or DNA stage where it can integrate, there's a potential for cure. And that's what's been the most exciting aspect of all these drugs that have come on the market. We don't have a persistent or latent stage. Now we do, there have been some studies that came out just recently where they had looked at sustained virologic response that patients had, and then maybe a year or two later, they actually did have a recurrence of HCV. So it may be the fact that you get massive amounts of virus made during infection, and you got to get rid of all of that virus to make sure that the patient doesn't have a reactivation. But it seems as if for a lot of patients, we have the potential for cure. Also note that the DAAs are never given as monotherapy. So as soon as you have more than one viral target, the antiviral therapy is best if you use it combined because resistance to one leaves the other active. And in this case, we have 3 possibilities.